Hello, everyone. I'm Michael McNutt with Weedy, and welcome to a Weedy Virtual Spotlight, Connecting the Dots, integrating electronic prior authorization with external care guideline vendors, case management, and claims systems. Sponsored by Itiliti Health. This is part two of a two-part series. It's my pleasure to introduce Michael Lunzer, CEO and founder of Itiliti Health.
Hello, everybody. Excited to have the opportunity to talk with you today about this very important topic of prior authorization automation. This series of webinars is really focused on helping drive a better understanding of CMS 0057 prior authorization APIs and how those can be used during the implementation process to ultimately streamline and automate the prior authorization process. Today is the second of two webinars going kind of deep on the details around the integration between various systems and how the prior authorization APIs work. Again, I'm Michael Lunzer, the CEO and founder of Itiliti Health, and would love to give Keith Brick an opportunity to introduce himself as well before we get started. Keith?
Good morning, everyone. Today we'll be talking about a few of the most important actors in this process: our payer, the EHR that they use, the intermediaries, the QHINs, I'm sorry, I'm going to start all over. Thank you, Michael. This is Keith Brick, and I'm our interoperability architect, and I'm happy to talk us through the technical systems that connect our providers, the payers, and the systems that the payers use.
Awesome. Thank you, Keith. So we like to start our presentations with kind of understanding some of the key questions that'll be answered as a part of the session today. And so those particular items are: how does the provider know the CRD endpoint for a payer? So how do they even get there? How does the EHR know where to go? How does the data flow between one organization and another? What does that routing process look like? And as a part of that, we'll talk a little bit about what is the data that flows within each of the different transactions. This is a little bit different than portions of our primary topic today, which is, how do these different systems connect? But I think understanding the data flows and the data that transacts between these different systems will really help clarify how the data routing happens. The next question is, how do transactions get to the policy or delegated vendor? And also really taking that to another level, how do those transactions get to the utilization management system? And then also, how do providers submit claims on these transactions that have prior auth approval? So what does that process look like? And what are some of the key data elements that are needed in order to really tie all of this together, from the process of a provider requesting a prior authorization, getting that information through to the delegated vendors, or getting policy data from guideline vendors, and then ultimately getting that back to a claim. So that's kind of the overriding topic we're going to talk about. We're not going to do much to refresh on the overall concept of CMS 0057, but I'll cover a couple of key points with this slide. This is a kind of an entity map of the various key elements that are a part of the prior authorization process with 0057 prior auth APIs. So on the left-hand side, you have either an EHR system that internally supports the application programming interfaces required for prior authorization APIs, or a Smart on Fire application, which is essentially think about it like an iPhone app. It's an application that can connect internally to the electronic medical record system and also supports the three primary transactions for prior authorization using 0057. Again, those three transactions are the CRD, Coverage Requirements Discovery, DTR, Documents, Templates, and Rules, and PAS, Prior Authorization Submission. So the next entity you have in the middle is the connectivity methods. There are various ways that an electronic medical record system or Smart on File application could connect to the payer's systems. Those connection methods are direct connections between those two systems, some kind of proprietary multi-party connection from a third-party organization that has created a mechanism for those things to connect, or a standards-based TEFCA QHIN technology system that can connect these systems together. And on the right side, you have a FHIR server, which is a common mechanism that payers utilize as essentially their digital front door that helps to ensure that transactions of different types get to the different destinations. And oftentimes the FHIR server can also perform translation functions for supporting or allowing systems that are not FHIR native solutions to be able to talk to FHIR systems. Other entities you have on the right side of this are for the CRD transaction. There needs to be some source of prior authorization rules knowledge. Oftentimes that's a database system. And then below that, you have the documents, templates, and rules system. And that's a tool that typically stores information about medical policies and guidelines and is typically a database. That DTR system can be a payer's DTR system, or the payer can choose to utilize a third-party delegated vendor as an entity that supports or publishes those policy guidelines and questionnaires. In some cases, the health plan may have two versions of those systems. They may have their own medical policies and guidelines, in which case they might have their own medical policy database. And then they may also use delegated vendors and third-party guidelines. So one of the things we're going to talk about today is how do those systems talk to one another? How do transactions get from the EMR all the way through to the appropriate destination for medical policy guidelines or questionnaires? Another key role in this process is the receipt of that prior authorization submission. When that prior authorization submission is delivered to the payer, there can be certain functions that can be performed for verifying if that prior auth can be automatically approved. And then somehow that prior authorization submission ultimately needs to end up in the utilization management system. I've seen diagrams from various organizations that have 20 or 30 different boxes on this type of a map with arrows going all over the place. And those are probably technically accurate diagrams. I think this version of a higher level picture is really helpful for most individuals to understand the goals of these systems, and then gives us a framework to talk about the various entities and the transactions that are going to flow throughout this process. I just realized I forgot to mention, of course, that you're welcome to answer questions through the chat or ask questions through the chat associated with the webinar. And our presentation today will leave ample time to answer those questions at the end of the presentation. So we really look forward to your questions. So again, as we've talked about, there needs to be a mechanism to route and get all of this transaction information from a healthcare provider to the payer. And the picture that I showed you previously on the right-hand side had one payer's example of what that architecture needs to incorporate. This picture obviously shows on the right side 3 different payers. So now we've got multiple systems In some cases, some of the payers are using the same vendor for their systems. And wonderfully, all of this information flows correctly to the right destination through the various mappings that take place in these technology platforms. One key opportunity here is to include a Qualified Health Information Network, or QHIN, in this picture, which can help streamline the directory and connectivity of the various elements in this process.
And there are
So
a few analogies
I
that
was just
will
I was just going
probably,
to ask you, Keith, if
yeah,
you could jump in and talk a little bit to both of these two slides and kind of where we're going next. Sorry.
there are a few analogies that we like to use when talking about this. The first one is the telephone analogy. When you pick up your telephone and dial, let's say you're trying to call a health plan, you don't need to know the payer's telephone service provider in order to reach them. Um, Similarly, when you are visiting a website on your computer, you don't need to know who their internet service provider is to go out and reach their website. You're going to contact your telephone company and they're going to route you, or you're going to contact your internet service provider and they're going to route you. In the same way, a qualified health information network provides registry services that help you, your APIs, and your machines understand where do I need to go in order to find the information I need for the next step. So um, we talked about the role of the provider and the EHR, or their electronic prior auth coordinator, which is that Smart on Fire app that helps them perform these functions. And on the payer side, we're talking about the Fire Digital Front Door and all of the services within the capability statement that describe how do I submit a new request for coverage requirements discovery? How do I submit a prior authorization? How do I inquire about the status of that prior authorization? So we'll talk about each of the pieces of information that the provider's system is going to use to make those requests, how the QHIN can help route it to the right payer, how the payer will then decide, well, what am I supposed to do with this? What information in here helps me understand the appropriate policies? And then how we can then connect that to our delegate vendors, for example, a musculoskeletal vendor or behavioral health vendor that might have the answers of, well, here's the prior auth requirement and here's the form you'll need to fill out. So that's the big picture. We're trying to make this work so that any provider can place an order, and the prior authorization requirements for that order can be found no matter who the patient's coverage is from.
Another analogy that we talk about a lot is thinking about this as the internet in general. There's everybody knows that we have IP addresses and internet destinations that ultimately get us from one end of this network to another. And when we talk about the transactions that are part of the prior authorization process, you can really think about these transactions in a browser or an internet perspective. So the first transaction that's part of the prior authorization process is the coverage requirements discovery transaction. Ultimately, what's happening in this transaction is the provider is sending a bundle of information to the payer or a payer's system, and that payer system is performing some database or various activities, queries on their end, and responding back with some information. The way this transaction flows is extremely similar to a browser-based transaction where a user is filling out a form on the screen, hitting submit, and that data is being sent to the payer, and the payer is responding back with some information that gets displayed on the screen. The difference being that instead of displaying information, oftentimes these transactions are taking place instead of in a browser. The EHR is the front end or the user interface for the display of the form and the display of the response. So the next element we'd like to talk to in a little more depth is what is actually in each of these transactions. And by the way, we're going to cover some of this information, and it will become much more relevant when we kind of turn the page and talk about how these transactions get from one destination to another. So Keith, could you talk a little bit more about the data that is sent from the provider to the payer as part of the CRD?
Certainly. And if this list of data elements looks familiar, it's probably because today your payer systems are asking for it up front in a prior authorization request form. We need to know the patient. We need to know who is ordering a given procedure. We need to know where that procedure is going to be performed, who the performing provider, that performing date, performing location all are. We need to know the procedure code or service that's being rendered. We need to know for that patient what insurance are we trying to bill, so which member ID and which plan and group code, and then what are all of that patient's member demographics, and if those member demographics are different than the patient, what's that relationship between the member and the patient. And then there's one really cool thing that gets included with the CRD request. This is part of the bundle of, it's a JSON structure that gets submitted over the web as an HTTP post. And we're saying, I've got all of this information. And by the way, if you need more information, here you go, payer. You can have a key that lets you come back and ask for more details about that patient's clinical record. So that FHIR authorization access token is intended to support real-time data retrieval during the CRD process. It's permission to come back and look at this particular patient for whom I'm requesting an order. If I'm the provider, I'm saying, okay, insurance company, Keith needs this procedure. If you need more information, come and get it. And here's what the payer side is going to respond with. So as they receive that bundle of information, they're going to say, all right, for Keith's coverage, given the procedure that you've requested and you've specified that they will be seen at a in-network location and by an in-network provider, um, we still need prior authorization under some circumstances, or maybe it's a gold card provider. You don't need prior auth. Or there might be additional information. So we have a conditional status that says prior authorization is required conditionally. And the very best one, the one I'm most excited about is, hey, all the information that you've given me tells me that you are sending this patient to the right place. I was able to go and retrieve the information I need to satisfy the prior authorization requirements. I've been able to fill out the rest of the prior authorization form for you. And if the API could do that in the background, it can actually tell us right away, yes, prior auth is required, but now it's satisfied. Here's your prior authorization number. It can be as fast as that. It can take place in less than 500 milliseconds in some cases, where we say, yep, you've given us all the information we need. We know that Keith's going to get that procedure. It's going to be in network and it's going to be covered. Here's your prior auth. If there are forms that need to be filled out, the CRD response is where we say, yes, you need to fill out a prior authorization form, and we're going to ask some questions. Here's where you can go to get that questionnaire that will walk you through the process of providing the information that the payer needs in order to provide that prior auth number. In the instructions that come back, we have instructions that are intended for administrative staff, so your clinical back office or your prior authorization coordinators at a provider organization. You also have clinical instructions that can say to the provider who is placing the order, we need you to document X, Y, and Z in order to satisfy the prior auth requirements for this given procedure. We can also provide back a link to the policy. So for example, in Epic, they could display a direct hyperlink that says, all right, you've ordered this thing, Keith's Insurance follows this policy when authorizing procedures of that nature. And the last thing is the feedback to the provider that allows the payer to say, you've ordered, for example, a given medication, which isn't on the formulary. This one might require prior authorization or might not be covered. Instead, you could consider this other medication that is on the formulary and would not require prior authorization or would be covered. So that type of provider feedback is the best mechanism for payers to communicate uh, information specific to what was ordered and help guide that provider to understand what the patient's coverage supports. Justin has a great question in the chat, which I'll answer right away. The questionnaire that is being provided back in a CRD response is actually intended for the provider and their staff to fill out. It's a questionnaire that is analogous to the paper form that a prior authorization requires a provider to submit today. So if they're faxing something in today that says fill in X, Y, and Z about the patient's medical history in order to qualify for a given procedure, that paper form is what's being represented electronically and, more importantly, computably in the questionnaire resource. All right, Michael, back to you.
Yep. So that was the overview of the CRD transaction. And again, what you can think about this is similar to a website, right? Your EHR needs to know what website to send the information to get a CRD response back. And the format and the data that it sends is predefined, so essentially universal among all participants that are using the CMS 0057 standard. So the next transaction that happens in a very similar way is the documents, templates, and rules transaction. And this is the scenario where the provider now, because of the CRD transaction, knows that there is a prior auth required for a particular procedure, and there needs to be some information gathered in order for that procedure to be approved. And so at this point, the provider sends over a request for that questionnaire and that information request. So Keith, I'll leave it to you to talk a little bit more about this
Yeah,
transaction.
and very similarly to the CRD request, the DTR request is going to include all that same information, and some of it might be fresh. For example, during CRD, the provider might have been placing the order, but not necessarily known where the patient is going to go for the surgery. Now, during the DTR transaction, we might have additional information available to us about who the performing provider, performing date, performing location would be. And now what we're doing is we're reaching out to that questionnaire package URL that was included in the CRD response. So we're going to take that information about our patient and we're going to submit it and say, for this procedure, for this patient, and for this coverage, what forms do I need to fill out in order to satisfy the prior authorization requirements? And the questionnaire package URL is going to return back a bundle of questionnaires. It could be one or more questionnaires that each contain a set of questions that, for example, could ask about the patient's medical history, their current experience with the condition, the treatment that they've had up to this point, and or the goals, desired outcomes from that treatment. So that information is captured in one of these questionnaires where you say, all right, provider or clinical staff and or EHR, if we have clinical query language, we can actually instruct the EHR to fill in certain parts of the form for the provider if the data is available in a coded and structured way. And we say, please answer these questions so that we can provide you a prior authorization. Within the questionnaire itself, we have questions and value sets, which are the sets of codes associated with each question. Value sets are really important because they allow us to do algorithmic processing, where we have, for example, a set of diagnosis codes that in a patient's medical history might automatically authorize them for a particular type of treatment. So, for example, if a patient has had a traumatic injury and you need to do imaging, well, that traumatic imaging is available because we know that the patient's receiving treatment for something that does require that type of imaging. Um, Similarly, we can, with those extensions, we can give instructions to the HR that say, uh, I need the list of the patient's diagnosis codes from the last 90 days, or maybe I need their lifetime list of how is their experience with cancer and oncology been. I need to look back in time and pull that information forward. Rather than having the provider type that information in or transcribe it to a piece of paper, what we want to do is we want to have the EHR render that information into the answer for us or attach those documents or other FHIR resources as part of the answer to those questions. So those are the types of things that we can do with extensions. Value sets, I'll add a couple of examples, are things like LOINC codes, ICD diagnosis codes, SNOMED medical concept codes, things that give us computable answers, as well as things like yes and no. Yes and no are a value set that's just a Boolean. But all of these things allow us to, ultimately our goal, allow us to do in the rules engine an evaluation of what has been submitted with the goal of providing very quickly an answer to that prior authorization submission, which is what we'll talk about next.
Before we do that, I'd just like to do a quick aside. the topic of questionnaires and policies is a pretty big topic. Oftentimes we talk about that in terms of policy codification and questionnaire codification. We're not talking in depth about this topic today, but we do have a webinar coming up October 16th with Weedy that will dive deeply into questionnaire design and management and policy codification. One quick thing I'll say right now, because oftentimes when this topic comes up, there's a lot of perception that this is a very difficult challenge and how can I ever convert my policy criteria into a questionnaire? And those associated code sets and CQL. It's a fairly technical concept. What we'll talk about on the 16th is more of an evolutionary approach to questionnaires that is compliant with CMS 0057, but takes some of the intimidation away from this huge challenge and allows you to be CMS 0057 compliant and evolve towards fully code set oriented questions, but not ultimately requiring you to do that on day one. So we'll talk more about that in a subsequent presentation. So again, we've talked about documents, templates, and rules. So how does the provider get that questionnaire, and then how do they fill it out? And again, that's going to show up inside the electronic medical record or the Smart on Fire application. It's automatically going to be filled out to some degree, and the provider is going to finalize their form that they're going to want to submit. And so the next step is the prior authorization support, or essentially submitting that prior authorization to the payer. When that happens, again, similar to the way we've talked about it before, it happens inside the electronic medical record system and is submitted in a similar type of transaction. Again, this one is called prior auth support, or PAS. And Keith will talk a little bit more about what is all included in that prior authorization bundle that is submitted.
Yep. And just like before, we need to describe which patient is this prior authorization for. And if you think about the forms that providers are faxing in today, the top part of it's always the same, right? It has the patient demographics, their coverage, and the provider information. But now what we're going to do is we're going to attach the questionnaire responses, which are the answers to the questionnaires that we learned about during CRD and DTR. We might additionally attach other things, the respondent documents that were indicated in those clinical instructions. For example, if I need to include a history and physical or a note about the patient's prior surgical experiences, that information can be requested as part of the questionnaire and attached either within the questionnaire or using the $submit attachment operation. So submitting the bundle of these things uses the $submit endpoint, and we can add attachments with submit attachment. These are the first step of prior authorization support, and they set us up by providing all of the information that the payer might need upfront as the bundle that today is being faxed. Now we're going to send it electronically. That's our goal. And what we're going to get back from the payer is an answer. Ideally, it's going to be an approve answer that includes the prior authorization number or admin tracking number that you can use subsequently in your claim. There are situations where the information that was submitted needs to be reviewed by a human. And in that case, what the payer will respond with is a pended status. When we respond with a pended status, what the payer can offer is either the ability to come and check on your prior authorization submission or subscribe for updates. Certain EHRs will soon have the ability to receive dynamically the updates for submitted prior authorizations. This is a way to get notified in real time. Otherwise, what you would do is you would come back and check maybe on a weekly basis or 14 days before the scheduled appointment. You could have some sort of schedule at which you would come in and inquire about the status of that prior authorization that was previously pending. And then on occasion, you'll have a denial that's related to missing information. If, for example, there's a required field that for some reason the EHR didn't fill out or the clinician or their support staff missed, that information can come back right away. So rather than waiting 7 days or for a letter in the mail about why the prior authorization was denied, what we can do is instantaneously say, this is what was missing. Please try again and include that information so that we can get you processed appropriately. So how do we inquire? The $inquire operation is it's one of those FHIR services that a payer system will have that allows you to inquire by example. So you would say, all right, I'm interested in Keith's prior authorizations for services ordered by Dr. Lunzer, and now we are trying to specifically look for the prior authorization for this particular surgical procedure or particular imaging procedure. You can optionally include that procedure code. And then, of course, the patient's coverage so that if we're sending this request to a group of systems, that the patient coverage can allow us to pick out which payer system is responsible for returning that feedback. The combination of patient and ordering provider is intended to give us a way, for example, if a prior authorization was submitted in one EHR, but now the patient needs to travel across town to the surgical center and have their prior authorization pulled up or inquired about in a different EHR. Now that second EHR doesn't need to have a huge FHIR bundle in order to find it. All they really need to do is correctly identify that patient and their coverage and the ordering provider. Those three pieces of information will help us find that prior authorization reliably. In the question and answer, I'll get to that one, I think, at the end, Timothy, but thank you for the question. It's a great one. In our denial reasons, specifically in the PAS submission, we have the ability to enumerate specific data elements that we require. And typically it's going to be, we require information that was part of the questionnaire, or we require information that is core to the patient's coverage or the requested procedure. And unless you tell us specifically which procedure you're trying to authorize, we're not going to be able to process a prior authorization. So really that's the intention of those errors. Go ahead, Michael.
So that overview of the transaction details kind of and the method by which they're sent, similar to a web page submission, helps to explain a little bit about how these transactions flow. So if we think about it from the perspective of that first transaction, first row is authorization required, or CRD. The provider EHR is sending that transaction through the network, and it ultimately reaches a payer's rule system for whether or not prior authorization can be approved. In the case of Itiliti Health, our product for that purpose is called PA Checkpoint, and it's a rules-based tool that says for this particular transaction, this CPT code requires prior authorization for this patient, or this CPT code is one that is delegated to a different vendor, or perhaps is going to be determined by policies and guidelines that are hosted by a third-party policy or guideline company. So in that case, Itiliti Health can, for instance, in receiving this transaction, either answer the CRD transaction or forward it on to the right delegated vendor or policy mechanism. Once that prior authorization required decision is made by the delegated vendor or policy vendor or Itiliti Health, it's forwarded back through to the EHR. In the case where it's a delegated vendor, the answer will be sent to Itiliti Health, which will then forward it on to the electronic health record system. So in this case, the description that we're giving you here is a scenario where Itiliti Health's PA Checkpoint is that tool that is knowledgeable by procedure code and patient and coverage. It knows what the appropriate decision support tool is going to be for, does it require prior authorization? So for instance, is PA Checkpoint going to be the decisioning agent there, or is it going to be a delegated vendor or third-party guideline company? Similarly, when either Itiliti or the delegated vendor answers that question and puts that URL for where to go for the DTR questionnaire, that information will be sent back through to the provider EHR. In the case where the systems have been configured to identify that Itiliti Health is always going to be the destination for the DTR, even if the delegated vendor sends back a CRD that says the URL for this policy DTR is the delegated vendor site, Itiliti Health can replace that URL with the Itiliti Health URL, because again, we are ultimately in that scenario going to be the destination that the EHR asks for the DTR questionnaire. So
And this is
again,
a great opportunity to answer Justin's question in the chat. Um, Justin asked, is the flow to third-party vendors easily interchangeable between Itiliti and the payer or additional delegated vendors? I think it would be part of the question here, where we would like to have one endpoint that supports all possible transactions. And the answer is absolutely yes. And in fact, that's the design goal under TEFCA, is that for a given exchange purpose, a destination or responder is going to have one set of endpoints, one set of URLs. Just like today, it's really unfortunate for a provider to have to go to an insurance page and then figure out, oh, I actually need to go over here in order to fill out the form, and then I need to submit it to this third place. We want to solve that problem in the CMS 0057 prior authorization APIs by saying, all right, for a given payer, we're going to have one digital front door that supports all of these services. And behind the scenes, those services are going to be able to connect out using the information that was submitted. They're going to figure out, all right, who do I need to connect out to in order to get the answer, and then deliver it back to the provider. This allows for a provider organization to say, I want to set up a direct connection with one particular payer, and I know that that one connection is going to handle all of my requests for patients who have that coverage. It also allows the network, the qualified health information networks, those intermediaries, to say, all right, I have a request for Keith. Let's look at Keith's coverage. All right, this coverage is handled by this server over here. And all of the requests are going to be sent to that server for Keith's particular prior authorizations.
And
And
this is really the key, one of the key topics of our session today, which is how do these different systems receive these transactions and how do they get routed from one place to another? And the beautiful thing about FHIR is it can be designed by the payer to be handled in different ways. So I'm actually going to jump back to the high level picture for a second, and we'll talk about that in terms of the routing options that you have. So for example, when these transactions come through the network, if, for instance, the CRD destination is ultimately going to be a delegated vendor or a third-party guideline company, there needs to be a source somewhere in this environment where the payer can easily configure their rules to say, starting today, procedure code 12345 is going to need to get to this delegated vendor. That source of truth or that routing configuration can be in Itiliti's PA Checkpoint product, or it could be configured in a FHIR server or any other place in the network. However, again, the payer needs a easy user supportable mechanism that allows them to create and manage that source of truth or those routing rules. In this case, what we've talked about is Itiliti Health is acting as the proxy. So we receive that CRD transaction. We know that for a particular procedure code, that procedure code goes to a particular delegated vendor, and therefore we forward it on or we proxy it over to that delegated vendor. Again, in that scenario, what Itiliti Health does, and our customers have told us that they like our approach, is that we make it really easy for a human to come into an administrative portal and configure those rules. Again, it is possible to configure those same rules in other destinations or systems in this fire infrastructure. The key thing for the payer that they want to evaluate is, where do I want those rules configured, and how easy is it for me to administer and manage those rule configurations? So I'm going to go back to our slide here. Again, we've talked about it in terms of CRD. The DTR transaction happens in a similar fashion. The DTR can either be answered by a questionnaire within the Itiliti Health Policy Management application, or in the event there's a third party that is the delegated vendor or a third party source of prior auth rules, that third party can be the destination that is passed through or proxied by Itiliti Health. Or, as we talked about, the fire server, for instance, could forward that procedure, that questionnaire request through to the delegated vendor. And I'll talk a little bit about a use case that we find occasionally. In some cases, we find payers that utilize third-party sources of policies exclusively. They don't have any of their own policies, and that third-party source of policies has a really good ability to handle the questionnaire capability. In many cases, those third-party sources of policies don't offer the is auth required or the CRD capability. In that case, Itiliti Health's PA checkpoint can be the CRD capability. And when we respond back telling the provider EHR where to go to get the questionnaire, we can directly give them the destination for that third-party delegated vendor or policy system. So there are different ways that these, think about them like Lego blocks, can be connected to ultimately get the transaction to the right destination. And that allows you to optimize your configuration. Again, similarly in the pass transaction, when a prior auth is submitted, if Itiliti Health is the knowledgeable source about your policy and rules for a particular transaction, that can come to Itiliti Health system and we can answer whether it's approved or not, and then forward it on to the utilization management system using FHIR, or we can proxy that submission of a prior auth submission and send it on to the delegated vendor or third-party tool, and they can then send that transaction on to the utilization management system. The reverse flow for the pass answer can either come through this chain of connections or directly through to Itiliti Health. And this is why we spent so much time on the details of these transactions. I hope it helps to explain how these transactions get routed to the right destination and the fact that there's a little bit of flexibility here. And ultimately, the key to making your decisions about where you want these roles to occur should really come down to how easy it is to manage these rules and where your organization configures them. We find some organizations that have IT departments that want to manage these things, but in some cases, those IT-related systems are harder to manage and harder to configure and require more resources to change. So that's really Itiliti Health, small commercial here. Our strength is the ability to support the configuration of these rules in a simple system. But again, we're an equal player in these environments, and we are more than happy to work in whatever strategy and approach the health plan has used to map out these transactions. The next slide just describes this in a little more detail when we talk about delegated vendors or guideline vendors. Again, the CRD request can be sent from the provider to Itiliti Health. Itiliti Health can route that to the guideline vendor or can answer it on their behalf. The guideline vendor can send that response to Itiliti, or Itiliti can, again, answer that response and send it back to the EHR. And when we talk about how this information gets to the utilization management system, again, there are a couple different ways that this can be architected. The third-party guideline vendors can be the organization that sends results back through to the utilization management system, or Itiliti Health can be that system that sends those back. Similarly, the response back on a submitted prior authorization can come back through the third-party organization and through Itiliti Health, or it can come directly through Itiliti Health or directly through FHIR back to the provider. These transactions are very standards oriented, and therefore it makes it easy for us to help you architect these in a way that allows you to manage them effectively, and route them appropriately and make sure that the data gets to the right source. One question that we get often when we start talking about all of these different systems, the perception can be that this could take a long time, right? We're flowing from one system to another system to another. There's a concern that this could take time, and these are real-time transactions. The important thing to note is when you think about these transactions, they're very similar, again, to you hitting the submit button on a web page and getting an answer back. When you perform that submit, that transaction is going through many different internet nodes and different systems on its way to its ultimate destination. That destination might need to process information and send it back to you. And as we all know, web pages are instant, more or less, right? So that's the theory here, is these transactions look complicated, but they're not. The key is that we all need to know what's taking place at a technical level to make sure that we've incorporated the various third parties and other systems that need to participate in this fairly complex environment.
There's a great question from Tom that I think this slide can answer. Tom asked, does Itiliti have a public API for delegated vendors, or does each vendor require custom integration? And the answer is actually in this FHIR logo here. What we're doing is following the DaVinci implementation guides, which are named in the federal regulation CMS 0057 as well as HTI 4. And the DaVinci implementation guides are the product of industry-wide collaboration to define what are the data elements we will need in order to route this request, satisfy this request, and what are the data elements that we will need in order to provide a useful answer. So where you see the FHIR logos on this slide, that is the FHIR industry-wide standard for CRD, DTR, and PASS. Those are the APIs that we plan to use, and we're going to use them in the same way when we are talking to the EHR as when we are talking to these delegated vendors. So if you go and attend a sales presentation from any of these delegated vendors about how we want to support CMS 0057 workflows, they're going to say, well, we would love to stand up a FHIR compliant or DaVinci compliant set of services, and we want you to invoke those services when it's our turn to answer the question, is prior authorization required? Or if it's our turn to provide a policy for a given procedure. The important part is that before the doctor can find that answer, there needs to be somewhere in the middle that is going to understand the business logic that says, for Keith's insurance, musculoskeletal policies are going to be handled by this particular external policy vendor. So that decision-making logic, that rules engine, is what we think of as PA checkpoint and what we think of as, in general, the role of the payer's initial policy-based routing.
So want to hit a couple more points that were part of the questions, and hopefully we've given enough insight to answer these questions effectively. The first one here is, how does the provider know the CRD endpoint for a payer? Keith?
Yeah, so in today's world, before TEFCA takes full effect, before we have every single system all talking the same language, in today's world, providers are looking at the back of a patient's insurance card to see, oh, what phone number do I call or what website do I call to look up policies. In the future, the way that we plan for this to work, and the way that we've designed for it to work industry-wide, is that intermediaries such as QHINs or Qualified Health Information Networks can provide directory services that help match a coverage and plan to a particular server. That directory will help answer that question of, for Keith's coverage, where is that CRD endpoint going to be? And that is a work in progress. I would say that industry-wide, it is not yet a fully solved problem, but our goal from a workflow perspective is for, on the provider side, registration to capture the patient's insurance details, transcribe it from their card, or maybe in the future we can scan a QR code that contains a smart health link. If that smart health link was pointing to Keith's coverage at a particular payer side service, then that could include all the information, in a single barcode. Or if they recorded as Blue Cross Blue Shield of California, in that situation, we could have Blue Cross Blue Shield of California have their URLs listed in the directory provided by the QHIN. In whatever workflow we end up supporting, the goal is for the registrar to capture the payer information, for the provider to select the procedure, and then those two pieces of information are going to find the URL for the CRD service that will answer the question, do I need prior authorization for that procedure? So
In the
yeah,
interim period, before all of the TEFCA QHIN capabilities are fully rolled out, it's my understanding that the EHR can be configured directly with an expectation of where to go for a CRD and to begin that process. So
exactly.
as you can imagine, that's not the long-term solution here for every payer and every provider to know where to find each other through proactively configured steps inside of each EHR individually. But again, that is an approach that works for this interim period and will allow frequent partners between providers and payers to be configured to talk to one another.
Exactly. And so that's how our pilots are doing it today, is a pilot provider organization can identify a payer that they do a large volume of prior authorizations with, and they can go directly to that payer and say, I would really like to submit these prior authorization requests electronically. Where can I submit them? Where is that API? We know that you're not required by the regulations to have it for another 16 months, but I'd really like to try to start using it today. And so you can today, if you have a payer that supports it, plug these in and map that insurance to a set of web services that you can begin using as soon as they're available on your EHR and on the payer or provider side.
So the last question that we had pre-programmed here is, what do providers need in order to submit claims? And how does that process get kind of completed? So could you speak to that a little bit, Keith?
Yeah. So during the submission process, what we're going to do is provide the questionnaire responses, the answers to all of the fields in that form that we were instructed to fill out during CRD. The questionnaire is what we retrieved during DTR. And during the submission, we need to include the performing provider, the ordering provider, the procedure service, all of those fields that we talked about as part of that submission bundle. And interestingly, this is also the same way that we will inquire about the status of a prior authorization. It uses what's called query by example. So you can take that same bundle of information and say, hey, I sent this to you before. Does it have a new status yet, or is it still pended? And so when we are going to check in on the status of prior authorization, we're going to take that same sort of bundle or a subset of information, just that narrow slice, the ordering provider, the patient, their coverage. We can take that information and say, please tell me the status of those prior authorizations. What we get back is that prior authorization number, and that prior authorization number is what we will use in the claim. So once we've successfully gotten to that final status of we submitted the prior authorization and it came back approved, that golden ticket is the prior authorization number. And that's part of the submission response or the inquire response. And it's also something that can be received from a FHIR subscription. So what this means from a workflow perspective is that doctor can place the order, the APIs can talk to each other in the background, and their prior authorization support staff can see, all right, Keith's got a prior authorization. It came back, it's got a green check, it's ready to schedule.
And to take that full circle, it's helpful to look at this slide again, where we've now, everything that we've done with regarding fire prior authorization approvals has ultimately ended up as a point of record inside the utilization management system. Usually the source of that prior authorization number is going to be that utilization management system. So in today's world, most organizations' utilization management systems already have a method of giving those prior authorization numbers to the claim system so that claims can be paid based upon a valid prior authorization number. So that helps get that claim, that prior authorization number back through to the claim system so that when a claim is submitted, a valid prior authorization number is what is circled back to get that claim paid. So I believe we've answered all of the questions that we planned to answer today. So next up, we'd like to talk a little bit about some of the questions that we've seen in the Q&A. And first one I'd like to cover is a question about, where does the actual prior authorization get initiated in the process? Does it start well, obviously, we've talked about it starting inside the electronic medical record, but there is still a lot of conversation about where in this process and who initiates that prior authorization request. For instance, there have been a lot of conversations about inside of the EMR, is it the administrator that today fills out a prior authorization form and is responsible for processing prior auths? Typically, that's called a referral coordinator. Are they the people that are going to be ultimately responsible for submitting a CRD, submitting questionnaires, and receiving the PAS transaction back? Or is some of this information going to be exposed to the actual physician? In which case, which actual physician should be the one filling out the prior authorization request? The question in the comment section was for an opinion on where this belongs. I would say that Itiliti Health's perspective on this is that this is going to be an evolutionary experience. We are seeing EHR companies kind of starting with the premise that today, maybe that information will start being interacted with by the referral coordinator. I think there are others in the ecosystem that prefer that physicians have easy access to this information so that right away, when they're sitting there with a patient prescribing a service, they can know this requires prior auth and it's gotten approved, so we're going to go ahead or not. There are physicians that say, I'm already burdened and I don't want to see that information. I want to keep the process the way it is. I think we're going to see some evolution in this category. For the easiest transition to move all of these transactions away from the fax machine and into FHIR, I think we're going to see the starting point probably be the referral coordinator or the administrator interacting with these. My personal opinion would be it would be wonderful if the physician also had the option to perform these transactions. But when it comes to who gets to decide, that's going to come down to the electronic medical record system companies. So one of the things that we find is physicians are not very engaged in this process of driving this standard. We'd really like to see more physician engagement. Other questions or comments, Keith, that you see?
I think Maria was asking about what percentage of prior authorizations are typically satisfied using our solution. And then if you want to also talk about the prior authorizations submitted today through manual processes that in fact don't need to be submitted.
Yeah, that's a great question. So ultimately, Itiliti Health has customers that are seeing about 85% of prior authorizations being answered instantly through this process. Those instant responses can include scenarios where the prior authorization isn't required, or where a provider is gold carded, or where a prior authorization matches rules inside of the payer that mean that it can be auto-approved. It can also be scenarios where the prior authorization meets the requirements of that prior authorization guideline. So there's a number of different ways that those prior authorizations can get an instant answer. Um, Again, of course, the exciting thing here is that through FHIR, we are going to see a larger and larger percentage of transactions being handled instantly. One of the keys to that will be the topic that, again, we'll talk a little bit more about on October 16th, which is the codification of policies and questionnaires. And we'd love to have you join us for that webinar, which will be performed through WEDI, and you'll be seeing more about that in the coming days. I know we're at time. I'm looking through to see if there are any quick questions. I guess there's one here, which is, when are EMRs required to support these technologies? Keith, do you want to talk a little bit about that, and then we'll
Yes.
close?
So payers and EHR software vendors are targeting that same 1/1/27 deadline to have these APIs up and running, ready to use. On the EHR vendor side, certified EHR technology definitions under HTI-4 are being expanded to include these APIs. And on the payer side, of course, we're following CMS 0057 guidelines.
So just a short 2-second commercial here. Itiliti Health is really excited to be talking with you all today about how this all works. We'd love to tell you how our solutions support these capabilities. We know that there are a lot of organizations that have questions and needs in this area. We'd be happy to engage one-on-one. And again, feel free to reach out to Keith or myself for a conversation directly. We'd be happy to talk with you further. And again, thank you for the opportunity to talk with you today.
Michael, Keith, fantastic presentation as always. Thank you very much, and thank you to Itiliti, the sponsor for this event. As Michael mentioned, on October 16th, there will be another presentation sponsored by Itiliti. Information is forthcoming. Please visit wedi.org, that's wedi.org, and click on our calendar for upcoming information on that event, as well as all our other events. On behalf of WEDI, have a great day.